Hello and welcome to the third and final episode of the fourth series of online education sessions brought to you by Salts Healthcare. If you have been unable to watch either of the two previous episodes where we explored diet and fluids for the ostomist within the first session, and then in the second episode more closely examined the specific fluid and electrolyte support necessary for ostomists with high outputs, then don't worry, it's not too late. Both episodes, along with all the other sessions, are available on demand at the Salts Healthcare website. In this final episode, we will hear from Sarah Cripps, who is a consultant gastropharmacist at Oxford University Hospital's NHS Trust. Sarah is a specialist pharmacist in gastroenterology and hepatology and has been so for the last 23 years. And for the last 10 years, she has been a consultant pharmacist in this speciality. She is also an independent pharmacy prescriber and faculty fellow for the Royal Pharmaceutical Society. Having had so much experience as a gastroenterology pharmacist, Sarah is perfectly placed to talk to us about the medications used to manage the challenging cohort of patients with a high output stoma.
So my name's Sarah Cripps and I'm one of the pharmacists at the Oxford University Hospital's NHS Foundation Trust, and I'm the lead for gastroenterology services. And the session I'm going to talk about today is the pharmaceutical management of high output stomas and the impact this has on drug absorption. Just to begin with some definitions, a stoma is the opening of the skin through which a section of the bowel is brought out. And the definition of a high output stoma or fistula is when the output from this causes the patient to become water, sodium and magnesium depleted. This generally occurs when the output is more than 2 litres over a 24-hour period, although this does vary according to the amount of food or drink taken orally. For example, if 4 litres was consumed and a 2 litre output therefore may not be a problem, but if only half a litre is consumed, dehydration is likely to follow. And a high output stoma usually occurs in up to 13% of small bowel stomas, rarely occurring if more than half of the colon is in continuity with the small intestine. So while a short bowel, which we would probably define as less than 200 centimetres of jejunum remaining, is the most common reason for a high output stoma, there are some other easily treatable causes which should be considered. For example, a newly formed stoma can often produce a high output, particularly in the early days, or if bowel is affected by disease or treatment, or if shortened by, say, a formation of a temporary stoma, as you would get in a pouch formation. Also, intermittent or partial obstruction is quite a common cause for high output. If you had a sudden history of cochlear abdo pain or swelling or visible peristalsis, and temporary stopping of the stoma are suggestive of this. The high output stoma tends in this case to occur as the obstruction resolves. A stenosis or at or near to the stoma is common and may be detected by visual inspection or inserting a finger into the stoma. A low fibre diet may help, but often a surgical resection is needed. Other causes include opiate or steroid withdrawal or the use of a prokinetic drug such as metoclopramide. In the perioperative period, abdosepsis with low albumin and ileus may occur. Also, C. diff infection or celiac disease are also associated with a high output stoma. So it's really important to confirm the underlying cause prior to treatment. The consequences of this are essentially grouped together as illustrated on this slide. So firstly, dehydration and thirst, cramps and tremor. So if you're having a high output of 1.5 to 2 litres or more a day, you get that associated water and sodium loss, and then hypomagnesia, magnesium or low magnesium in the bloodstream, which is associated with tremor. You've also got the stomal problems, so frequent emptying of your bag, leakage or difficulty, and then problems with the skin surrounding the stoma site. And also undernutrition, so due to dehydration, you again get decreased output also of important nutrients. High output stoma also affects the absorption of medication, primarily oral through the oral route. The oral route is the most commonly used route that we have to administer medicines, and most of these are absorbed in the small bowel of the GI tract. In order for medicines to have a pharmacological or therapeutic effect, you need to have sufficient amounts of the active form of this medication to reach the site of action. And absorption is going to be affected by the gut wall surface area. So if you have a smaller length of gut in situ, then that's obviously going to reduce the surface area for absorption, and also the gut transit time, primarily through the stomach and small bowel. So if this is very rapid, the time this medicine is going to be exposed to be absorbed is obviously going to be reduced. And that's associated with what we term the oral bioavailability, so the amount of active medication that actually reaches the bloodstream. And it has been shown that in patients with ileostomy or pouches where the surface area and transit time may be higher, this is reduced. Some medication is designed to be released further down the gut in the large bowel or colon. So if you don't have a colon in situ, then obviously that type of medication isn't suitable. And also some medication is designed to release in certain specific points within the gut length. So that may be slowly throughout the gut as it goes along, or at certain pHs, and the pH of the gut varies as you move through from the stomach and then into the small bowel. So preparations like modified release, then the effect of those is going to be affected. And we'll pick this up a little bit towards the end of the session. So this slide just depicts visually what the output may look like depending on the length of the jejunum in situ. But it's also important to educate patients to recognise the signs of a high output stoma and the consequences of that, and some general tips which we will talk about in a bit with regards to oral intake and some medication that they may require or need to dose titrate. This slide just highlights the amount of GI fluid secretions that we produce. And this varies depending on which part of the literature you look at, but we estimate around 7 to 9 litres of fluid enters the lumen of the GI tract. And in patients who have a functioning intact tract, then most of this will be reabsorbed. So you have fluids secreted in saliva, in gastric juices, mainly in response to food. And you have your pancreatic enzymes and bile, which are released in the early part of the duodenum before the chyme is further diluted in the first part of the jejunum. Fluid is ingested not only from drinks, but also fluid content of your diet. And then as you move further down the GI tract, you have reabsorption of fluid and electrolytes. So you only get about 1 to 2 litres of fluid actually entering the colon, most of which is reabsorbed, leaving a soft stool. Now, in patients who do not have a full functioning GI tract, so you have sections removed, then it may be possible to try and reduce some of these secretions, which in turn will reduce the output and then subsequent dehydration. A prime example would be to reduce the amount of fluid being secreted from the stomach. And we could do this, for example, with a proton pump inhibitor. So when it comes to patient care, I think everyone needs to recognise that patients who have a high output stoma or fistula are really best managed on a specialist ward by personnel, by the MDT that understands this cohort of patients and can manage them appropriately. Obviously, that may not always be possible. So if patients are admitted to a general ward, I think it's important that the nursing staff and the medical staff refer to the specialist team for support and advice as needed. Because a poor management of high output stomas can lead to quite serious consequences such as dehydration and nutritional electrolyte deficits, as we've already mentioned. When it comes to safe discharge, we generally recommend that if the stoma output is still exceeding 1200 mils a day and the patient is not biochemically stable, it is unsafe to discharge. We will certainly advise against that. When it comes to supplying medication at discharge, some of the medicines we use very large doses, such as loperamide, so it's important that patients have enough to take home with them before running out. And obviously patient education really is paramount. It's really important they know how to safely manage their stoma and to reduce the output as appropriate. So the main treatment protocol that we would follow is firstly to confirm the cause. Secondly, to replace fluid and electrolytes. We need to rehydrate the patients, stop their thirst, and certainly in the initial stage or in the emergency situation or acute phase, then we would replace this fluid intravenously. We would give oral glucose electrolyte solutions. These are referred to as isotonic solutions, and we'll touch upon those in the next few slides. And then plus or minus magnesium supplementation, depending on the blood level. Some people may consider subcutaneous fluids before parenteral, particularly if there's a concern with IV access. We would then need to consider how we're going to reduce the intestinal losses. So, as we've already mentioned, the use of anti-secretory drugs such as a PPI is useful, and also antidiarrheal agents such as codeine or loperamide. We would restrict oral fluids, that's hypertonic fluids, so water, fizzy drinks, coffee, tea, and use a more isotonic solution that way. Nutritional support obviously is very important, and there'll be additional sessions led by the dietitian that you can refer to for this area. Monitoring of bloods and symptoms is really important, and we would recommend full blood counts, using ease, calcium, magnesium, and phosphate. Also a random urinary sodium concentration and serum magnesium. And essentially, we are aiming to keep the urine sodium above 20 millimoles per litre. And urine sodium is the best gauge of hydration status. And I think when it comes to output, I can't emphasize enough that it's really important that you keep accurate fluid charts. And that's something that's commonly not done, particularly in general ward areas. So that's really important. And often patients are the best placed to do this themselves. So in a normal bowel, you have water and sodium being reabsorbed in the colon. But in a short bowel, so you're looking at 1.5 to 2 meters of your jejunum or ileum remaining, a hypertonic fluid, such as water, tea, fizzy drinks, can increase the stoma output. This in turn increases sodium loss because essentially there's insufficient capacity to reabsorb the sodium. So the sodium concentration of the small bowel fluid is always, whatever the oral intake, about 100 millimoles per litre. But hypertonic fluid will result in a net efflux of sodium into the bowel lumen, and this is lost then through the stoma. So to enable water absorption to occur, then we need to ensure that the luminal fluid content has a sodium content of about 90 millimoles, 90 to 100 millimoles. And this is what we would have in what we would term an isotonic fluid. When you use an isotonic fluid with this concentration of sodium in it, it means that the sodium and therefore water is not drawn from the blood back into the bowel, but will facilitate absorption of both sodium and water. This in turn slows down the output and reduces sodium and fluid loss. So the key thing is, if you're feeling thirsty or you feel dehydrated, don't just drink water because it is hypertonic. And as I said, it actually exacerbates the problem, increases the output and makes the dehydration a lot worse. You also need to be careful with hypertonic fluids, such as in elemental diet supplementations, because they will also cause a net flow of fluid into the bowel lumen. So again, water and sodium depletion is exacerbated. Essentially, the higher the output, the higher the sodium losses. So what do we mean by isotonic fluids? Well, there are different recipes, for a better word, that are available. You have ones called St. Mark's, which was originated in St. Mark's Hospital. There's the WHO formulation. Here in Oxford, we also have our own formulation called the OUH. You can also use diaurolite, but that's double strength. So the volume of fluid you're using to make up it is halved. And as you can see in this slide, it tells you the concentration of sodium that results. We're aiming for the magic 90 millimoles, and they're all made up essentially into 100 mils. Most recipes for isotonic fluids are essentially managed by the ward dietitian. Some are slightly more palatable than others, so it's always important to check with the dietitian as to which one should be used, and to some extent patient preference. And I guess what's readily available at either at home or on the ward setting. This is the example of the St. Mark's solution. So these are the main ingredients down the side. So you've got glucose powder, sodium chloride, which is table salt, and then we use either sodium bicarbonate or sodium citrate. It tells you how much in grams, how much you need to add, or it's probably easy just to say how many teaspoons are needed. And then you just put that in a litre of water, best chilled overnight and then enjoyed the next day. For any solution that you make up, you should use it within a 24-hour period. Anything that's left, which shouldn't be, but that should be discarded. With diaurolite double strength, if you're just having it sort of a standard supplement, you would have 1 sachet in 200 mils of water. But in double strength, you would make it 1 sachet up in 100 mils of water. So if you were scaling that up to make a litre of solution, you would essentially use 10 sachets. Diaurolite is a licensed medicine, so it's really important that this is prescribed. If the patient was an inpatient, I have to say, in my experience, we would recommend that any isotonic formulation was prescribed, so it's easy to ensure that the patient does receive sort of an aide-memoire. But for diaurolite, which is a licensed medicine, it is much more important to do that. So when it comes to trying to increase palatability and compliance, because it's a little bit like drinking seawater, we recommend that you keep it as cold as possible, but don't add ice cubes, because that's obviously diluting the concentration, because it's extra fluid. We may suggest using a straw. The Oxford recipe, we do flavour with squash, although some people try and avoid adding other liquids like orange juice and things, because there's a concern it can alter the electrolyte content. But we do use a bit of pink grapefruit squash in Oxford. And citrate appears to be a little bit more palatable than bicarbonate powder. And then the aim is to drink 750 to a litre of this a day, while restricting intake of other fluids to about half a litre. So that's the isotonic fluids. Patients with hyperstomas also can become quite severely electrolyte depleted. So although there may be a little bit in those isotonic fluids, such as potassium, you may need to replace potassium and certainly magnesium in addition to that. So with potassium, you generally get a negative balance when the jejunum is less than 50 centimetres. And magnesium, a deficiency is quite common. It doesn't appear to be a correlation between magnesium balance and the jejunal length, but often patients require quite aggressive replacement. And usually with potassium magnesium, we often have to replace this intravenously because the oral preparations can actually cause diarrhea. So you're actually exacerbating the stoma output. So just to be aware of that. And then other things like zinc, calcium, folate, selenium, iron, vitamin B12, etc. They should be checked every 4 to 12 weeks, and they may indeed need replacement depending on the blood level. How can we reduce intestinal losses with drugs? So we're going to now look at some antimotility and anti-secretory drugs. So some examples of antimotility drugs that we commonly use in high output stomas are loperamide, also called Imodium, and codeine. And these both act on opioid receptors in the gut to achieve a slowing down of the gut transit or reducing bowel movements, and that in turn allows more contact time, so increases absorption, both of nutrients from water from food, and medicines. At the doses that we use, these two would be classed as prescription only medicines, so POM. Both of these are best taken 30 minutes to an hour before food and bedtime, and that allows the drugs to sort of start working before you eat. And you probably get better outcomes if you use them both together. Just a point to note that if the stomal output increases with using both of these antidiarrheal drugs, then you should consider partial obstruction, which obviously warrants further investigation. So looking at these in a bit more detail, we begin with loperamide. So the standard dose is usually between 2 and 16 milligrams 4 times a day, although you can go higher. I've written here maximum of 80 milligrams a day. Personally, I have seen a little bit higher than that, but it would be very unusual. Certainly any doses above 16 milligrams a day are both unlicensed and should be guided by a specialist. So if you went into a shop and saw loperamide on the shelf, you can't buy it over the counter, there's a big warning that says no more than 8 tablets or 16 milligrams in 24 hours on the label. Just be aware that obviously for ileostomy patients or pouch patients, this needs to be ignored. It is safe, but obviously under the right management conditions. When it comes to side effects, loperamide actually you get very little absorption because of its mode of action. It doesn't cross the blood-brain barrier compared to codeine. So you don't get the sedating side effects, and you don't get the dependence that you are commonly associated with codeine. Loperamide can, however, cause abdo pain, can cause a little bit of bloating and nausea. So obviously the higher the dose, you're more likely to get these side effects, which may limit dose titration in some patients. Loperamide comes as capsules, tablets and melts, and we generally prefer tablets because they can be crushed, mixed with water or soft food. You can open up capsules, mix the contents with water or jam, but generally the absorption, particularly in short gut, is not so good as a tablet. There is liquid preparations available of loperamide, 2 different strengths. Obviously, the one most commonly available is 1 milligram in 5 ml, but the doses that you would need of that, that we would commonly use in high output stomas, that's a lot of volume of liquid. And actually it contains glycerol and artificial sweeteners, which in high amounts can actually exacerbate output and increase diarrhea, so not very well tolerated. We generally say if you're needing doses above 16 milligrams, 20 milligrams in a single dose unit, then we would use the higher strength liquid. Popping out 2 milligram tablets is sort of repetitive strain injury. So for some patients, a liquid may be preferable. Unfortunately, with a higher strength liquid, it is what we describe as a specials medicine, so not readily available, and it has a very short expiry once opened, so may not be practical to have on the shelf. Now, just a warning about high-dose loperamide, which caused a lot of angst when it was first published, particularly amongst patients. So patients need to be aware that actually when they are given higher doses, it can be associated with cardiac problems. That being the risk of QT prolongation and arrhythmias. So patients should be made aware of that potential risk. And obviously, if they have underlying cardiac problems, then the use of this medicine in high dose should be used cautiously, and obviously assessing risk versus benefit. So the British Intestinal Failure Alliance guidance issued some advice, and that recommended that with any patient who is going to be given high dose, then you should perform an ECG to detect prolonged QT interval, then after the dose has been increased, so you can compare. The half-life of loperamide ranges from between 5 and 19 hours. So steady state could take up to 5 days, between 1 and 5 days to achieve. So it's important that you repeat the ECG within this period, and then obviously after any further dose increase. So as I said, anyone with pre-existing cardiac history or hepatic conditions also, or if taking any other medication that can prolong the QT interval, so things like ondansetron, high dose use, you should use very cautiously. When it comes to toxicity in counselling patients, then symptoms such as lightheadedness, or if they faint, then that's a sign that there could be something wrong. So it's really important that they alert medical advice or seek medical advice as soon as possible. And like with any MHRA warning, then we recommend that a yellow card is completed. So moving on to codeine, another antimotility agent that we commonly use. For this, the standard dose is between 30 and 60 milligrams up to 4 times a day. And we generally do not exceed that dose. You don't titrate any further, as you may do with loperamide. And that's mainly because of the side effect profile. So lots of sedation, drop in blood pressure can make people feel quite nauseous. And obviously patients such as the elderly would be more prone to those types of side effects, or if they had underlying liver conditions or severe renal impairments. So you just need to be mindful of that. And codeine is available in both tablets and liquid. And obviously the tablets can be crushed. So we're now moving on to anti-secretory drugs, and we've mentioned these earlier on in the session. So these are the proton pump inhibitors. We used to use ranitidine, which is an H2 antagonist, but that's now been withdrawn because of safety concerns. And essentially a PPI is more effective in switching off acid secretions. And you get about a litre and a half of acid produced by your stomach each day. So if you can switch that off, then obviously then that's not coming out through the stoma. But it's essentially if you are what we call a net secretor. So output is greater than all intake. And the standard dose that we would use is 40 milligrams or equivalent of the omeprazole once to twice a day. You're basically aiming for the stomal pH to be higher than 5, pH of 5. Now, PPIs, whilst they're effective in these situations, are associated with side effects, which includes drops in magnesium, which can also be associated with a high output stoma, and drops in sodium. Long-term use is associated with osteoporosis, cardiac problems, GI infections. So the minimal dose that can control output is advocated, and actually it's worth regularly reviewing the need for a long-term PPI. And certainly if it's not having any effect, then it should be stopped. Another anti-secretory drug that has been used, but rarely these days, mainly because of the side effect profile and its efficacy, is octreotide. And octreotide works by reducing gastric, biliary and pancreatic secretions. This slows the transit time, and there obviously increases absorption of water and sodium. And with this, if you were going to trial it, we would probably start with 50 micrograms 3 times a day for a three-day trial period. If there's no benefit, then we would stop. If it was a benefit, the practicalities of giving that regularly are quite challenging. So we often convert patients to a longer acting preparation, but that's quite associated with high cost. And in some places you have to apply for funding. The side effects of octreotide, it's an injection, so that can be painful to administer in some cases, and it is also associated with gallstone formation. So as I said, because of the side effect profile, the practicalities of administration, the financial pressure of long-term use, its use is pretty limited. So just to conclude, I'm going to spend a couple of slides looking at the impact of a high output stoma on drug absorption. As we've already mentioned, this is going to be impacted by the residual length of gut you have left in situ, and also the functional integrity of that remaining gut. If flow through the gut is high motility or high transit time, that's going to reduce the time for the drug to be exposed and be absorbed. And that's going to be affected by where in the gut the drug is designed to be released and absorbed subsequently. So these considerations will have an impact on clinical outcomes, which you can obviously assess by improvement in conditions, symptoms, also drug levels, which in some cases we may be able to measure. And if you aren't absorbing enough, you may need to think about dose titrations or a different route to oral. So you're basically bypassing the gut. So you may need to increase the dose to have a therapeutic effect, but often increasing the dose is associated with an increase in side effects, which may not be tolerated. You may consider shortening the duration between doses to have an increased, so little and often, to increase the amount that's absorbed, or consider an alternative route of administration. So that may be through a topical patch, through subcut or IV route, which in themselves may have access or practical issues associated with them. And this slide just highlights perhaps some of the more common drugs that you need to be mindful of with high output stomas. So as we've already mentioned, if it's an MI preparation or enteric coated, then we generally avoid those in stoma patients because you can't predict where the drug is being released, and it invariably may not be released in the ideal place. So the amount, the therapeutic effect or bioavailability is going to be hindered. Oral iron, so patients who are anemic may need iron supplementation, but oral iron in itself can cause diarrhea and or constipation, and can cause soreness around the stoma site. So invariably we would opt for an IV supplement if they were anemic. As we already mentioned, with magnesium, potassium supplements, given orally, they can cause diarrhea or increase the output, whilst the opposite is true with calcium and aluminium preparations, which can cause constipation. So in those cases, if blood levels are low, then you may need to consider an IV supplement instead. Digoxin has what we call a narrow therapeutic index. So if the potassium levels are low, which may be as a result of a high output stoma, then you get increased toxicity. So you need to be really careful with digoxin dosing. Diuretics can increase the risk of dehydration. And laxatives and prokinetics increase transit time. So you need to be careful when you're using other drugs in combination. And that concludes the session. Thank you for listening.
As stoma care nurses, it's really beneficial for us to work collaboratively with other members of the multidisciplinary team to ensure that those patients with a high output stoma experience minimal side effects and receive the best possible care. For those of you who haven't yet had the opportunity to watch the episodes 1 and 2 as part of the Discover Series 4, these episodes, in conjunction with this final episode, brings together a detailed and comprehensive overview from other healthcare professionals involved with the care and management of patients experiencing high output stomas. Thank you for watching this episode and all the other episodes in this Discover series. I do hope you've enjoyed them. This episode, along with the previous 2 episodes, can be viewed at the Salts Healthcare website. Each episode can be paused and replayed at your convenience, giving you the time to write notes or reflect on certain aspects of any of the sessions if you require. Please click on the link at the end of this episode or from the main Discover series page on the Salts Healthcare website to access the evaluation form. On completion of this evaluation form, you'll be redirected to a page enabling you to print out your certificate of attendance. If anyone has any follow-up questions, then please do email us at discover@salts.co.uk. Thank you again for watching and following this series. We do hope you have enjoyed the sessions and are able to use various learnings in your own clinical practice. Looking forward to seeing you all next time.